230-237-6793. The reason that might be important is if you have any last minute test questions, I'd be the guy to ask. And my contact information is not on Canvas for you guys anymore because James, like I said, has kicked you to the curb already. My email address is kind of simple to remember. It's DERM PAC, DERM, Physician Assistant Service, 2000@yahoo.com. That's my email address. So I volunteered yesterday, and somebody asked me, do you just see DERM patients who they volunteer? That was the idea. We volunteered at this place since my church started it up like 20 years ago. And now it's turned into this big thing where all kinds of people volunteer there. Do I just see dermatology patients? Well, that was the idea. But it's turned into where there's not that many of them around. The people that go there to get free care don't all have rashes and zits. They all have diabetes, high cholesterol, hypertension, hypothyroidism, and almost everything but dermatology, where your patients that you'll see in the military, a lot of them have dermatology type conditions. So, the weirdest thing that I saw yesterday, I won't violate HIPAA, but I'll tell you before I get started. I saw a guy came in supposedly for a rash. And I thought, ooh, got excited when you see a rash, you know. And he'd been in a follow-up for a rash. He'd been in like last week to see somebody, and they couldn't fix his rash. So they were going to send it to me to fix his rash. So I walk in there thinking, oh, I'm going to fix a rash. And the guy said, well, I'm really not here for a rash. So, okay. All right. I was happy though. Well, okay, what can I help you with? The guy said, well, I got a problem down here. You know, it's all about underneath where the sun don't shine. I said, okay, well, let's see. So he drops his pants. And he has a scrotum the size of a softball. No trauma. Afebrile. I would think it would be painful. He said it wasn't painful, but my Lord. This is not a Mike Booth exaggeration. Have you ever seen Texas red ruby grapefruits in HEB? That's the size of this scrotum. And you guys have had urology, right? You know what paraphimosis and phimosis kind of stuff is? Where the foreskin doesn't retract kind of stuff. He had that going on too. I'm thinking, Jesus Christ. I didn't say that. And I didn't like, oh man, I didn't do any of that. That would, patient complaint type. Don't do that stuff. That's your inside voice. Don't let your inside voice come outside. So what do you guys think it was? No, what hyperseal? Good guess though. Not cancer, but that's a good guess. Not hernia. No, it didn't hurt. No urinary problems. You say it wasn't urinary problem. I couldn't imagine. He might have been lying to me too. They don't always tell you. They didn't tell the last person what it was. It was epididymitis. And I've never seen a case of epididymitis like that in my entire life. So one of the things the reason I bring this up, besides this, like the craziest thing I saw yesterday, all I saw yesterday was like asthma and diabetes and have to learn. So even if you become specialized, you still got to remember the diabetes stuff. So I didn't have an ultrasound, didn't have anything like that. So I took the old pin light out to see if I could visualize anything. I didn't feel the bag of worms kind of stuff that everybody looks for epidemic. This was like one big giant worm. It's like holy moly. So send them to the emergency room because I'm not 911. This is a free clinic. It's a very expensive free clinic, but we don't have that stuff. Anyway, they came back and they texted me last night saying it was epididymitis. I won't tell you how this guy got this because we're in mixed company and it's embarrassing. And I'm an old guy and I don't talk about stuff like that. And I don't even realize that stuff like that goes on. But it does. Some of the stuff that you will see, you probably already can imagine, you will end up having to treat, and people do crazy things to themselves. People will do crazy things to themselves. Soldiers will do crazy things on weekends or TDYs or whatever. They do crazy things, so you will see some stuff. But yesterday, that was the thing that I saw, and it will scar me. I will take that to the grave with me. All right. Anybody have any questions about yesterday? Because today we're going to talk, I'm going to tell you a little story, children, about itchy things, gross zombie skin falling off type things, and then we're going to talk about some zits. It shouldn't take the entire 2 hours. I won't bore you with any more stories like I did yesterday. So, I know you're studying pediatrics, right? That's the thing right in front of your thumb right there, right? So did you guys talk about atopic dermatitis in pediatrics for this test? Is this your first PEDS test?
Yes.
It'll be on one of your PEDS tests. And some of the things we're going to talk about today in the viral stuff will probably be in PEDS too. Did you guys talk about viral things on PEDS this time around? Measles, that kind of stuff. Fifth disease, hand, foot, and mouth disease. We'll talk a little bit about that today. Not much because you're going to get pounded with it in pediatrics and everything. So I'll tell you a little bit about it today. All right. So let me wound up and get started here. Let me get my little thing out here. That's my son got that hat for me when he was in the Navy. He was a nuclear power submarine kind of guy. So he's a strange kind of guy. He's very introverted. Stays in his room all the time, plays Pokemon and video games, and very smart, majoring in computer science, engineering, nuclear bomb stuff right now. But he was one of those guys that like to go down a submarine and just sit in one place for 3 months at a time, get ready to blow the hell out of Russia or something like that. Never had to though. So now the post 9/11 GI Bill he's living La Vida Loco over there in San Antonio. We're paying for all this stuff. All right. You guys ready? I'm ready. Urticaria, itchy stuff, exanthems is things that pop up on your skin that ain't supposed to be there. Drug reactions are exactly what it says. Then hypersensitivity syndromes. That's what this one's going to be about. There's the list of all the crazy things we're going to talk about. Urticaria. Urticaria and angioedema. Showed a picture of this the other day. This guy's having an allergic reaction. He's not a happy camper. It's a recurrent whealing of the skin. Wheals are another name for hives. They're kind of transient. They kind of come and go. It's like a physical exam finding of you having an allergic reaction. Angioedema is the one that occurs down at the dermal subcutaneous level. Urticaria is more kind of deep dermis type stuff. There's a list of all the different types of urticarias. There's a lot of them. All those different kinds of things make your skin itch and cause hives and wheals. Yeah, you can have aprogenic urticaria. You can have, I guess the weirdest one that I saw that I didn't believe when I was a second lieutenant was a guy that said, came in on a sick call saying that he got hives every time he did PT. Not that I heard everything. Oh, man, hives, you just break out in hives, PT, you know. When I was a second lieutenant, I changed sick call hours because people always try to get out of PT by going on sick call. So I changed sick call to well before PT so I could get them in and out before PT started. But this guy really did. So what I did, which I shouldn't have done, that's why I'm telling you this story. He said he got hives every time he did PT, and I said, oh, BS. That's what second lieutenant PAs do. You're just trying to get out of PT. So I had him get down and do some bend and thrust. Well, guess what? He started getting hives and swelling up all over that. And I'm like, holy crap! Every day after that, I started carrying around the Benadryl IM pins on me and epinephrine because I'm afraid somebody's going to go down on me. I needed to give them a shot. Anyway, I ended up giving some Benadryl, some O2. I didn't say I'm sorry. Never say you're sorry.
I've got that.
You've gotten that?
No, I've had it yet.
Well, then get down and do some PT before, so we can show everybody not what this is. You're the guy who runs all the time, right? Did you go running yesterday?
No, it's not Saturday, but, you know, I have to take a Zyrtec about an hour before I run, or the night before, or else I'll break down class.
Well, damn. You have a profile for that?
They don't know about it.
Yeah.
Are you're afraid they won't commission you or something because of it?
And we'll find out.
All right, so that's another reason why people that are showing up in the future are going to be commissioned the day they get here, so they won't need any waivers. Because everybody's trying to hide something. Short story: when I was here at PA school, I did something stupid, and I ended up going to the ER, needed an X-ray, and there was something that wasn't right on my X-ray. I didn't tell anybody about it either, so I understand where you're coming from. All right. So, mast cells, I told you that urticaria is for mast cells, that, you know, whatever can cause the mast cells being released, the histamine being released from the mast cells, which are usually located around blood vessels, whatever causes that to happen will cause urticaria, the itching phenomenon. What it feels like, itchy, uncomfortable. If it starts getting into the short of breath kind of thing, what would that make you think? Madness is getting ready to happen. So, might be progressing to angioedema. So when this kind of stuff happens, you need to be ready to do what? Tube somebody. Innovate. A nasal cannula is not going to get it. Have them sit over in the corner and have happy thoughts is probably not going to help them out too much. So just be ready with the Benadryl. If they start having shortness of breath, difficulty swallowing, 911 time. Itchy mouth, throat, get them with the Benadryl. Don't give them a 50 mil, 25 milligram Benadryl pill and kick them out the door. We're talking a 50 milligram shot of Benadryl in the butt. All right, what it feels like, firm, faint, pink. It used to be on the slide. It's called Peau d'Orange in French. Is what they actually feel like. Orange peel-like feeling if you touch them. And they're transient. They can kind of come and go. That's what they look like. You got a lot of pictures of what they look like. Different types. Physical urticaria can last minutes to hours. Dermatographism is that fancy word I told you about the other day where you can elicit the hives by, like the tongue depressor. I got a picture of that here in a second. You can get it from heat. You can get it from the sun. You can get it from jumping in the water. You can get it from getting cold. They're all physical types of urticaria. This used to be a test question. It's not on your exam this time. Don't blow it off because it'll probably be on your pants. To diagnose someone with chronic urticaria, which is different than acute, is it has to be greater than 6 weeks, okay? Greater than 6 weeks. 6 weeks or less than, equal to or 6 weeks or less is acute urticaria. So you can have an itchiness going on for 3 or 4 weeks, it's acute. You're thinking, damn, this has got to be chronic, this lasts more than 20 or 30 minutes. It's not chronic. So that's important for the allergists when you're getting ready to treat them. All right, it's a diagnosis of exclusion. Have you guys heard that word before? Chronic urticaria, you've got to rule out everything before you can label somebody with that. If they have chronic urticaria, that's med board stuff. Med board stuff. Okay, if it's going on for greater than 6 months, that's a homeboy over there. Yeah, he didn't say that. He didn't say that, all right? But you got to forget about all that. We don't have any blue falcons in here, do we? You guys know what blue falcon is?
Yes.
You got blue falcons over there? I see some Air Force guys over there. Blue falcons. All right. All right. Diagnosis. It's kind of easy to figure out. Establish whether it's true urticaria or not, if it's just something cray-cray going on. People can cause themselves itching iatrogenically. You can cause people to itch. You can give somebody something that they never had before. They can cause them to itch. A true allergic reaction, do you think you're born with it? No. You develop it. That's why when people have bee stings, they get stung by bees and everything, and they don't break out in hives or whatever. Then all of a sudden, that one lucky bee comes around and you get crazy. Same way with allergies. You develop them. work up, draw some labs. There's one test that's not on there. It's kind of a garbage pail test. I used to draw it all the time for allergies. It's called a RAS test. Have you ever heard of that? You can order it. It tests for rats, cats, bats, asps, whatever else you can test for and everything. But it's called a RAS test. It's a blood test. It'll come back and it may or may not show that they might be allergic to, I don't know, ragweed or something like that. It might tell you something a little more specific. What you really want to do is send them to the allergist if you're trying to figure out exactly what it is. But if you want to be a good primary care PA, order these labs and maybe throw in a RAS test too. Something I learned over the years. Treatment, again, Benadryl. Avoid it if you can figure out what the hell it is. H1, antihistamines, Benadryl, Atarax. Be, like I said, ready to give IV steroids and IV Benadryl, snow somebody, and maybe some epinephrine. Chronic, second generation, like homeboy over there taking that Zyrtec, and then avoidance. More pictures of hives. Again, these are transient. They can either be dermal when they get down to the dermal subcutaneous level. You're looking more at angioedema. If somebody shows up to you and they have a lot of swelling around their eyes, swelling on their tongue, swelling where I was talking about before with that guy that I saw yesterday, you need to be thinking it's getting ready to be 911. You need to start looking for a shot of steroids, a shot of Benadryl, and have the epinephrine ready. Call 911. These are all hives. Lots of pictures of hives. That's why I can go through these slides next pretty quick. So this is an example of dermatographism where they don't have any hives, but just like homeboy over here told me, hey, every time I do this, I break out in hives. Will you get, your little tongue depressor and say, oh, come try on me. And then you scrape on their thing, and all of a sudden, it pops up. You believe them then. You don't have to bend and thrust, like I did when I was a second lieutenant. Don't have to bend and thrust till the hives pop out. You can do this. Ice. So you freaks out there using those ice cubes. They break out in hives. Stop. Stop using the ice cubes. That's probably tell a little bit more what we're talking about. Angioedema. Worse than hives. This is hives that have gone crazy. These are deeper hives. It usually will, when you start having this, you have to worry about airway compromise. That's the biggest thing you need to start worrying about. There are deeper reactions. Could be anywhere, but most common, like I said, lips, eyes, tongue, trunk, genitalia, hands lead to anaphylaxis. You try to stop it before it gets to anaphylaxis. All right, treatment, IMPO antihistamines. When somebody's lips or tongue are swelling, don't give them a pill. You might not be able to swallow it, and by the time you're manipulating something back there or looking around, all you're doing is poking the bear. You don't want to poke a bear. You take your head off, it causes bad things to happen. So just get ready to give them something IM or IV. Have the epinephrine ready. Get ready to intubate. Anybody ever intubated? You guys ever intubated anybody before? They'll talk to you about rapid sequence intubation in your emergency medicine things. You're not going to have that stuff to rapid sequence intubate anybody in your aid station. You're not going to have the stuff to do that. But they're not going to give a damn. If their throat's closing up and they're losing their airway compromise, they're not conscious of it anyway. Just go ahead and do it. Don't wait for the ambulance. So get used to feeling for those things. And the worst thing is when you're looking to intubate somebody is not being able to find it. Not being able to find your laryngoscope. Everybody been stationed in Colorado Springs before? Anybody there? You good? Have you ever heard of Pinyon Canyon?
Yeah.
I went up to Pinyon Canyon a few times in preparation for going somewhere nastier. And was in a dust storm out there once. Really bad dust storm. And we just got there, drove up on site, and a soldier, was allergic to dust. And we're in the middle of like a hurricane dust storm. Dude can't breathe. They come loading up I mean, you can't see 5 feet in front of you. We were just getting out of our vehicles. And they come up with this guy on a cot that they grabbed out of the back of a Humvee, had him on there because they didn't have a litter, and this guy was almost comatose. This dude was allergic, and he was like all swollen up, and I'm thinking, where the hell is my larynx go? Cut to the chase, I found it just in time. But he didn't give a damn about a rapid sequence innovation. You just gotta need to know where the hell that thing is. So, I'm telling you that, not to scare you, but that's one thing you need to know where the hell it is, when you're, especially if you're 911. And you're gonna be in a situation pretty soon, unlike old mics of EPA, they can call the ambulance. You're gonna be 911. So something like that, laryngoscopes, know where they are, Haldor Thorazine, have some of that for the cray-crays that are gonna be around you with bullets. You need a Thorazine, people. I've had to do that before. You don't want to get shot. Have that with you too. And be ready to innovate. All right, pictures of angioedema. Somebody shows up with lips, eyes, like these pictures. Be ready. We used to have a picture of this lady here. I don't know, the last person that was here before I came back took it out, but I had a picture of her before or after, where her face wasn't so swollen up. Well, she looked normal. She didn't look like the pumpkin head, you know. So before and after, if somebody shows up like that, they're probably not going to be able to talk very well. Give them a shot of, I'd go right to the epinephrine. Okay, so viruses stuff. We'll blow through these because you're going to get them really big time in pediatrics. Measles, complex spots. When you hear complex spots, think measles. White spots on the buccal mucosa. What else if you see a kid, because a lot of these things are kids, if you see white spots on the buccal mucosa, what else could it be? Especially if they're little, like oral, like thrush, you ever heard of thrush, Canada? So if you saw spots on the buccal mucosa, how could you differentiate between the two? If you scrape it and you see this little blood or something like that, it's probably Canada. They need some nice cotton swish type stuff. Complex spots you're not going to be able to scrape off. What else could it be? Oral cancer. Usually oral cancers on the tissue, or it's going to be on the lateral side of the tongue, or the gums are usually not on the buccal mucosa. But biopsy it if you don't know what it is. Usually on kids, you know what complex spots are. I have a few pictures of them. All these viruses we're going to talk about, how would you treat them? Other than if you can use antivirals on some of them. Supportive care. That's all it is. So there's not really brain surgery. You just treat them supportive care. Fever, give it some time. You know. Complex spots. So what that is. Viral exanthems, hand, foot, and mouth disease. You guys have heard that. You'll hear a lot about that in pediatrics. Usually starts in the mouth. We'll start having these lesions that will progress to the hands and feet. That's the diagnostic picture you will see on exams. Will be a rash, and you'll see somebody's mouth, their hands, and their feet. What do you think it is? Hand, foot, and mouth disease. All right, you're going to have a little bit of low-grade fever, some viral type things, macular, papular type deals. You can put mainly anywhere, but mainly hand, foot, and mouth. Supportive care, antipyretics, antihistamines at the itch. And there's some stuff called Orabase. Have you guys heard that before? Orabase, you know, Kilog Orabase, a little steroid with a little benzocaine type stuff on it. You put on oral lesions, it doesn't hurt so much. You kind of use them maybe without this ulcers also. Somebody has some hurting ulcer type things in their mouth. Kilog and Orabase helps out a lot. Fifth disease, erythema infectiosum. Slapped cheek, it looks like somebody whacked them in the face. Rarely papular, very lacy rash, usually if it's inside the mouth. Again, it's peritic. Supportive treatment. Slapped cheek appearance. I go through these kind of fast, but you get a lot more of it. Kawasaki's disease, I used to This used to be a test question too. Used to get a lot of people on it. It's not on your test. Mucocutaneous lymph node syndrome, I used to put that on the exam instead of Kawasaki's disease. There'd be people that would bite on that every time. Keep me out of test book. But this is normally a young kids type disease, usually 2 to 3-year-old kind of thing. High fever, 101 to 104. What you're gonna see on a physical exam with this, usually, something called a strawberry tongue, usually looks like a strawberry, where their tongue is. You can have a lymphadenopathy. Fever lasts about a week, off and on. You treat it again supportively. There's an example of a strawberry tongue. It's not a red beefy tongue like you would see with iron deficient anemia, something like that. This looks like strawberry. You guys bought your strawberries, put your chocolate on it for Valentine's Day yet? That's what I gotta do this afternoon for my wife and my daughter. My wife's going to Wisconsin tomorrow on Valentine's Day, for Christ's sake. Tomorrow, Valentine's Day, guys. Did you know that? Oh, shit. Just letting you know. Just letting you know, don't be a loser. When I leave here today, I'm going right to HEB and getting some strawberries and getting my chocolate on for that stuff. Because at 3 o'clock in the morning, I'm dropping my wife off the airport, and I'm just going to be sitting at home being sad. Me and my dog on Valentine's Day. Oh, Jesus, my sad story. All right. Okay. Well, when you're in marriage as long as I have, what the hell, right? What the hell? I'll just drink a Shiner-Bock and forget about it. Okay. One of the things that happens after the strawberry tongue, that usually lasts for a few days, is the tips of your fingers and your toes start peeling off. The fancy word for that's disquamination. There's a scarier thing that I'll talk about here in a minute. The zombie stuff that I alluded to with the peeling of skin here in a second. The toxic epidermal necrosis. We'll talk about that here in a second too. But this is usually with kids with Kawasaki's. All right. Drug eruptions, drug reactions. What thing do you think causes these? I mean, you guys are smart. Drugs. All right, so how do you stop it? Do you stop the drugs? There it is. I don't know if you can go through the slides. All right, so these things pop up in certain places for some strange reason. Occasionally, in the history, you're going to get it from the history. You've got this rash, they come in, they've got this spot that pops up that looks kind of weird. They think it's cancer or something like that. And one of the things you ask in the history, have you started anything new? What have you changed in your diet? Yada, 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 yada. Oh, I started some pepper the other day because I'm crazy and I have seizures or whatever. And you go, oh, maybe this is a drug reaction. Okay? Because usually some of the mental drugs can cause these things, and antibiotics. So, most common macular papillary multiform rash. So it means it looks like a rash like anything else, unless it's a single solitary spot. Where do you think the single solitary spots pop up? Most common places if you're a guy on your penis. You have guys running to the TMC if they have brown spot pops up on their penis. You know, so they'll think that they got something bad. Just stop, whatever medication it is, brown spot goes away. But that's the most common spot. But it can pop up in other places too. All right. Again, don't wear tidy whities. Boxers. Fixed drug eruptions appears specifically after you start the drug. Penises, lips, hands, face, where it normally pops up. Here's a few crazy pictures. They'll tell the medic they have a rash, and they won't show the medic, and all of a sudden they'll drop trowel like the guy did on me yesterday. And then you'll see what they really got. Don't freak out, don't say anything crazy, but ask them if they ever started any kind of drug. This is very common thing to see. Stop the drug, reassure them that it'll go away. You don't need to biopsy it. Stop the medication. If it itches a little bit, trim supportively. Stop the medication. All right, last part of this block. erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrosis, erythema nodosa. So let me give you the bullet on this one. The bottom line up front. There is a concept out there that these are all kind of similar. You either start out with a virus, and these are all worse cases of erythema multiforme. They can all be different variations of that. They just get worse and worse and worse. And it has to do with how much of their body surface area is involved. Okay? And this is the one where erythema multiforme will have something that's called target lesions. So another thing that has target lesions is what? Lyme disease, right? You learn that in infectious disease. These target lesions look like Lyme disease, but they usually have a blister in the middle of them, or another name for blister is a bulla or a vesicle that will burst and form a crust. So you might see them after the vesicle's already burst, but it'll have a target lesion with a little scab or a blister in it. So if it's a small area, it's probably erythema multiforme. They start getting really sick, and their skin starts falling off like zombies. Then you're worried about Stevens-Johnson or toxic epidermal necrosis, and then you need to send them to the hospital. Okay? The erythema multiforme, maybe it's kind of self-limiting, it might go away. But once skin starts falling off, you don't need to say, follow up with me tomorrow. Okay? They need to be seen in a burn unit because they will die because of their skin falling off. Because they don't have that protective barrier anymore. There's some theories behind it that they can get IgG to help their immune system, but it's kind of BS. All right, once your skin starts falling off, and greater than 40% of your skin is falling off, you're kind of teeth-a-knee, as I say in French, so you're done. All right, if you like pictures, this one picture, if you're a picture person, will tell you everything you need to know about these conditions. If you're not a picture person, then bear with me for a second. Erythema multiforme is acute, usually immune modulated type of syndrome. It's broken down into two groups, major and minor. Severe mucosal involvement. So mucosal involvement is not just your mouth. It's everywhere there's mucous membranes. All the moist parts. Downstairs, inside, eyeballs, everything. And depending on how much of that's involved is how bad it is for you. When I was going through chemotherapy for leukemia, one of the things that happened to me, because my immune system got so I didn't have any of this, thank God, but I had this thing called mucositis. You guys know what mucositis is? Mucositis is basically all my mucous membranes started sloughing off. Not happy at all. I mean, it was scary. Anyway, but I'll show you a picture of it, but you can imagine what's going on and what can happen. Etiology, usually herpes like this. Viruses, herpes, erythema multiforme. About 9%, starts with a herpes virus. Doesn't mean dewdrops on rose petal. It means if you have target lesions, herpes might have exacerbated erythema multiforme. You probably also have some dewdrops of rose petals. Herpes, most common. And then otherwise it could be mycoplasma pneumonia. You have target lesions, like I said before. Mucosal membrane involvement. That's what a target lesion looks like. It's that little bulla in the center of it. Again, if you don't see it when the bulla's there, it's got a crust in the middle of it. Where Lyme disease, you have your classic target lesion. I showed you a picture the other day of a granuloma annulare. That's not this. Granuloma annularis just has that border on it that's clear. Someone asked me, well, how can you tell that's not a fungus? Because everybody knows about ringworm. Ringworm has that border on it, but it's kind of crusty. Granuloma annulare has that border on it, not crusty, and central clearing. This has that with a blister in the middle of it. So physical exam, morphologically looking at it, that's how you can kind of tell the difference. So I expect you to be able to do that? No, not yet. maybe after phase 2 or anything, but I just want you to know that's how, when you're looking at that and trying to come up with a differential, that's how you kind of start thinking about it. All right, targets. Target lesions, those are all in different stages. Some of them have the bulla, some of them have the crust. Prodrome of what? Herpes, probably, 90%, maybe a little mycoplasma. Okay. Usually on the dorsum of hands and palms, the times that I've seen it, with erythema multiforme, it's on the dorsum of the hands or the feet. Again, mucous membranes, 70% of the time, are also involved, but you won't necessarily see the target lesions on the mucous membrane. Once it starts getting on the mucous membranes, you have to start worrying about it progressing to those other bad things I was telling you about, where stuff starts sloughing off, okay? Then you'll have some disquamination, like Kawasaki's had the disquamination of the finger and the toes. This will have disquamination everywhere. And based on what percentage of the body, you learn about burns, body surface area, what type of thing it is. This is like same kind of deal, body surface area. Those are the differentials, just like any of the other things, same differentials. They appear pretty quickly after you have had this viral type syndrome pop up. It lasts for weeks. They said prednisone might help a little bit with this. It's usually self-limiting. Antivirals, if you have this, what medications are good for antivirals? Cyclovir, Cyclovir, Famvir, Cyclovir, 2 Phillips, and for the, you give them the herpes lecture, don't you, James? Don't you do the herpes types? I think that's one of the ones that's coming up. Why I remember that when you're treating for like herpes simplex 1 or 2 is 2 pills for the lips and 4 for the hips. All right. Target lesions. Just a lot of pictures of the target lesions. All right, now we're talking about the progression. Stevens-Johnson syndrome, disease of the skin, mouth, eyes, and genitals. High fever. It can last a few days, initial presentation, but once it starts getting to the mucosal membranes pretty quick, it needs to be in your differential. So like I said, if someone shows up to you and their mouth's peeling, their eyes are peeling, don't dick around with it, pardon the word. They might show up down there too. You send them to the hospital, because guess where these people need to go? The burn unit. They need to get treated in the burn unit, because the number one thing, why do you think these people die? It isn't because they're peeling their skin. It's because they get septic. They get infected. They don't have that skin barrier that's keeping all the bad cooties out. All the cooties are getting where they don't need to go, and they get septic. So once people's skin starts peeling, other than the Kawasaki stuff, you need to send them to the hospital. These next things we'll talk about are just progressively getting worse. So, this is one thing I haven't told you, and I'll go through the slides pretty quick. How do you know the difference other than the body surface area? If you really wanted to get smart, like I told you the first day, if you see a blister and you really don't know what the hell it is, biopsy it. Because if you biopsy the blister, what the pathologist will look at is where the skin is separating, the blister is separating. Depending on how deep it is how bad it is. So where the epidermis is splitting, or where the dermis is splitting, is how more prone you are to becoming septic. So that's how they diagnose it. That's how they confirm it. Other than the body surface area, is with a skin biopsy. So if you see blister, you don't know what the hell it is, and it hadn't got to the peeling out from the mouth and all the other craziness, do a little 2 millimeter punch biopsy on it and send it to pathology. You might save somebody's life. You might save somebody's life. Biopsy. Looking for the skin split in the epidermis to determine Stevens-Johnson's from toxic epidermal necrosis. Don't wait for the greater than 40% of your skin sloughing off before you send it to the burn unit. Biopsy it. What happens is you have a direct toxic effect to the skin. Drugs is 90% of the cases for Stevens-Johnson syndrome. Erythema multiforme is virus. Herpes is 90-something% of the cause of it. There's a theory that they're all related, but with Stevens-Johnson's, drugs is 95% of it, and allopurinol, NSAIDs, other types of medications, mycoplasma seems to be it. There are some drugs that can cause it. Don't worry about the list. Don't worry about memorizing the list for phase 1. Again, if the drug's causing it, eliminate the drug. If you're worried about it, biopsy it. Treat it that way. If their eyeballs are peeling off, you send them to the eyeball doctor. Okay? If somebody has oral mucosa that starts peeling off, it's getting ready to start peeling off everywhere else. Send them to the ophthalmologist. Not the guy at Target who gives you your glasses. Not the optometrist. They need to see the ophthalmologist. Okay? All right. Differential, same as the others. Again, she doesn't look too happy. Drug eruptions are mainly in the differential, but drugs causing this for the most part. Skin starts sloughing off. So when I had mucositis, that's what my lips look like. Those aren't my lips. That's what mine look like. The inside of my mouth too. It didn't progress to my eyes, but it was in other places. And everything. It eventually got better over time. But when your immune system starts going down, that kind of bad stuff starts happening. These are really bad pictures. You wouldn't be seeing that in the TMC. Burn unit. They need to go to the burn unit. All right, we're almost done. Toxic epidermal necrosis is like Stevens-Johnson's. More surface area involved. High mortality rate. That doesn't mean morbidity. That means high mortality rate. Why? Because of sepsis. Direct toxic effect of the epidermis. How do you know? You get a sample of the epidermis. How do you get a sample? Is with a biopsy. So how do you tell the difference 100% from Stevens-Johnson's to TENS? Is a biopsy. And that's where they can see what is dying and what level of the epidermis. The deeper it is, just like with skin cancer, the worse it is. Okay. Medication is the most common cause, same as Stevens-Johnson, so that's why they think they're related. Erythema multiforme is the herpes virus. That's how you can differentiate it on a test question. Okay? In the real life, what the hell, you won't know. You know, I wouldn't know. On a test question, that's how you differentiate. Morphology, again, it looks like the other. It has the Nikolsky sign. Have you ever seen that word, Nikolsky sign? That's what this is. Skin sloughing with just touching it. It doesn't have to be toxic epidermal necrosis. You can have Nikolsky sign with Stevens-Johnson syndrome too. The Nikolsky sign just means that you can manipulate and the epidermis starts sloughing off. Nikolsky sign. Again, everywhere there's a mucous membranes. Poor prognosis. Management, burn unit, as soon as possible. All those things to try to help them out. Be quite honest, there isn't a whole lot of stuff that helps them out. If all their skin starts sloughing off, it's kind of too late. So you want to be kind of aggressive with the treatment. I think we're almost done here. All right, that's what I already told you about. I think they're kind of related. Don't worry about that. For as test purposes, just know that it's a body surface area percentage is how they clinically kind of determine it. So a picture of it, and don't worry about erythema nodosum or pyogenic granuloma. If you see these things, which I don't think you'll see, they're on there because they're on the pants and the pannary. So when you're getting ready to study for the pants and the pannary, look at these things. But they won't be on this exam. All right, so, all right,
take a break, and then I'm gonna tell you about zits, and we'll be finished.